All right, great. So hello again, everybody. I'm Gail Iwamasa. I am the chair of VA section in Division 18, and I am super thrilled to introduce the webinar that we have today, which is extremely timely and very practical, and have been hearing from lots of folks in the field who would really appreciate support and consultation in this area. It's working with patients who use hate speech in treatment, and we're going to focus on ethical issues. And our presenters today, as you can see on the screen, are Drs. John Billig and Dr. Tom Mullin. I'll get to their amazing achievements in a minute. But first, before we do that, just want to remind folks that Division 18 is considered the home for VA psychologists in the American Psychological Association, along with other public service psychologists who work in different settings, such as community mental health, state hospitals, Indian country, criminal justice, police and public safety. And so if you aren't already a member of Division 18, we will plug the website into the chat box. And yes, thank you, Marcy. I'm so sorry. Those folks who work with folks with serious mental illness. And so thank you, Marcy, for reminding me. So I will be plugging that link to the website in the chat box in just a minute. Multitasking is not in my wheelhouse these days, so I'll do that in a moment. What we are going to do is let Dr. Billig and Dr. Mullin do their presentation. If you have questions, please post them in the Q&A, and I will do my best to monitor that, and then hopefully we'll moderate a discussion at the end of the presentation. So now let me introduce our speakers. Dr. John P. Billig is Chief of Integrated Ethics at VA's National Center for Ethics in Healthcare. Before joining the National Center, he was a psychology supervisor at the Minneapolis VA healthcare system. Over the course of his career, Dr. Billig has served in a number of roles, including co-director of the psychology training program, program manager for primary care mental health integration, and chair of the Vision 23 Psychology Professional Standards Board. In his role as a healthcare ethicist and co-chair of Minneapolis's Ethics Consultation Service, he's worked as a trainer, coach, and mentor to improve integrated ethics and the ethics consultation service at the facility and throughout Vision 23. Dr. Billig earned his Ph.D. in clinical psychology from the University of Minnesota in 1993 and is board certified in clinical psychology from the American Board of Professional Psychology and was a VA University of Chicago Ethics Fellow in 2011 through 2012. Dr. Billig also serves as a member of the Ethics Committee for the American Board of Professional Psychology. Dr. Tom Mullin is a psychologist and the assistant coordinator of the PTSD clinical team at the George Wallen Department of Veterans Affairs Medical Center in Salt Lake City. He's a consultant also for prolonged exposure training throughout VA. In addition to consulting, he's deeply involved in the training in the clinic, supervising graduate students, psychology interns, psychology postdoctoral fellows, as well as nursing residents. He holds academic appointments as adjunct assistant professor in several departments at the University of Utah, including educational psychology, clinical psychology, and psychiatry. He also served as president of the Utah Psychological Association from 2015 to 2016, and is currently a member at large on the Utah Psych Association board. So without further ado, here you go, Drs. Billig and Mullin.
Well, thank you so much, Gail, for that very warm and kind introduction. Just for those who aren't aware, we're actually doing this presentation. It's sort of our second iteration of the presentation. So Tom and I did this last year within VA for mental health providers in our community-based outpatient clinics. And we got a lot of positive feedback, requests for the slides. In some cases, could you come and do a presentation at our facility? Most of which we didn't have the bandwidth to be able to do. But when Gail approached us about doing this for Division 18, we both, I think, kind of jumped at the chance to be able to provide this presentation for you. As Gail mentioned, I'm at the National Center for Ethics in Healthcare within VA, have been there for about 3.5 years. And Tom had a few words to say.
Oh, yes. Yeah. So and thank you again for inviting us to here. So I've been at the VA here in Salt Lake City for the past 16 years, actually, and I'm glad to be part of this. And, one of the things that in terms of the second iteration of this is really in the comments is really kind of addressing the elephant in the room when we're talking about working with patients who use hate speech in particular, is that like, for example, me, I'm a white cis male, and being in this role of being able to talk about this, I have certain kinds of perspectives, I have certain kinds of experiences, and I'll acknowledge that my experiences can be different about this. And I think it's important as a part of this to at least keep the discussion going. I think, these are hard discussions, and at whatever level, in order to continue to talk about this is going to be important. So the struggle, the process, putting these out there is going to be a big part of this. And this is part of that process of that. So anyway, just want to add that to this.
Thanks, Tom. So first disclosures, I guess Tom provided some of the first disclosures, which should be obvious to most who are able to visually see us, that we're both white males and both white cis males. I also happen to be gay, but I think, recognizing that, some of the statements that are made directed at people who are other than us is important, and we'll be covering that as we go through. But other than that, we don't have any other conflicts to disclose, and just reminding people that the views that we express here are those of ourselves and do not necessarily reflect the position or policy of VA, the US government, or the VA National Center for Ethics in Healthcare, where I work. So for our presentation, there's really three main objectives that we have. So one, in sort of understanding how to effectively respond, we really want to look at some of the ethical underpinnings that would help guide the ways that we would respond to patients who use hate speech or engage in other inappropriate comments or behavior. We'll describe several ways to react to inappropriate comments from patients or family members, and then provide some resources, some helpful resources that can be used to help address the situations in which patients or families make inappropriate comments. So you all may have heard statements like the ones that are presented on the slide here. Examples of, I don't want to see one of those people. They should go back to where they came from. I'm so sick of those liberal fags getting their special rights. You should go after that cutie at the front desk if she's not already taken. Do you want to just make out here in the hallway with me? No offense, but I want to work with someone who looks more like me. And you notice that some of these comments are sort of directed towards other people or about other people. And there can be implications. Does the person who's making the comment mean that I am one of those people? Or I'm one in with the patient, and those people they're talking about are other people. And sometimes it can be even directly targeted towards someone, the person that they're talking to, the provider that they're talking to. In some cases, it can be really ambiguous, and it can lead to those doubts. So, being a gay man, especially early in my career, there might be innuendos or comments made about gay people, and I wasn't always sure. Do they suspect me and this is their way of directing it towards me, or are they talking about somebody else and thinking that I am not one of those people? So when hearing these comments, there can be various reactions. It can be helpful to understand those reactions and how to respond. So the article cited here, it's in the reference list, is a recent Journal of the American Medical Association article by Amy Nicole Cohen. And it talks about various kinds of inappropriate behavior, especially verbal behavior by patients and families. And she says that in some way we should find a way to call it out and make it explicit, and then how to respond to it. Now in her art, it's basically a one-page article, it's relatively brief. It is describing a context that is a medical context and largely talking about medical providers, trainees and such. But I think it really has some important points that can apply to any of us who provide direct patient care. So one of the things is just recognizing that this happens, that patients and families actually engage in behaviors, particularly verbal behavior, that is seen as not respectful. And also, it's very common that as health professionals, especially when this first happens for us, we don't know how to react or don't know how to make or even make excuses for the disrespectful behavior. You know, we're supposed to be, to some extent, patient advocates and there for them, so we might excuse the behavior. A very common experience is to have what she calls personal paralysis. So that freezing, like deer in the headlights, when encountering unexpected behaviors that sort of seem surprising or are offensive. And in those reactions, there can be various attributions that the clinician ascribes to themselves in trying to understand the behavior. So one, there can be a very strong emotional reaction when the behaviors happen. There may be a tendency to look at oneself and say, is there something about myself that could have elicited the behavior? So, you know, for example, you know, when I would somehow get veiled or even direct comments that were derogatory towards gay people, I would wonder, well, are they somehow saying something about me? And is there something that I did in my behavior that maybe it made it obvious or was offensive? You know, what did I do that might have elicited the behavior? How we attribute what happened to ourselves can really have an impact on the relationship, and it can even sort of impact sort of what happens in an interaction, the purpose of interaction. And it's particularly important to be aware that for trainees, this can be sort of a complex series of reactions and trying to work out how to effectively respond and how to understand both the patient's behavior and their own, given the various power dynamics, not only between them and patients and families, but between trainees and their supervisors or even their peers. So let's turn to establish sort of some baseline or standards to determine ethically how might we look at a range of ethically justifiable options. So what are some of the ethical underpinnings for how we might respond? Well, one is to really understand that patients who are seeking medical care or psychological care have specific rights. And we, comparably, we as health professionals have specific duties when we're providing care. And there are minimum kinds of behaviors that are required when we're treating any patient. And basically those minimum requirements have to be in place for every patient in every circumstance. And we can look to some formal ethical standards that can help us determine sort of what specific behaviors might we engage in. And, you know, a number of these standards are supported by both legal standards and regulatory sanctions. So, you know, healthcare entities have patients' bill of rights. There's joint commission standards. And within VA in particular, there's a Veterans Uniform Services package that determines what services all veterans who are eligible for care are entitled to receive. And then, as you are aware, health professions have their codes of ethics. So as psychologists, we have the ethics code, and there can be other kinds of consensus documents in various professions. So what do those standards say are our duties that we have as healthcare providers? So one of the most basic duties is when we are treating patients that we treat them with impartiality. So each patient is treated with equal regard and concern. And that means that we neither grant any kind of special privileges to particular patients, nor do we deny aspects of care to some patients that would be routinely provided to other patients. And it's important to remember that this includes patients who are obnoxious or belligerent or use offensive or abusive language. And we always have to guard against allowing our own feelings to affect our judgment about the patient's rights to receive the best quality care we can provide. That said, there are limits to our ethical duties that we have. So, for example, patients who make requests or demands for care that is not appropriate, that's not sort of an indicated treatment for what they have, or for things that might be illegal or unethical, those requests or demands should never be honored. And to remember that no one, including patients or their families or partners or their advocates, has the legal or moral right to sort of make any of us act against our own conscience. A colleague of mine used to say, and I repeat this often, when patients would make sort of unreasonable demands or would want some kind of care that was not really indicated for what their problem was, she'd say, I refuse to be a bad provider. I refuse to provide you bad care. So no one can make you be a bad psychologist or other discipline if you happen to be a physician or social worker, nurse, or therapist. And that you actually can set limits on how you will respond to patient behaviors. So how might you do that? Well, one of the first steps is really stepping back and trying to understand where the patient is coming from and what might the patient's statement say about what's really valued to them, what's important to them. Is there in some way even offensive or inappropriate speech that is made by patients or behavior? Might it reflect underneath it their values, what's important to them, especially regarding healthcare? Or for that matter, what their fears are, what things that they might be trying to avoid, or sort of their vulnerabilities. And so the challenge becomes, how might I sort of acknowledge what was said and not ignore it while setting limits and maintaining that focus on what the purpose of the clinical encounter is? So one is sort of recognizing just the context of patients coming to see us. Recognizing a lot of patients who come in, they are going to experience discomfort when interacting with providers in any setting. And particularly for those of us who are engaged in psychotherapy and other psychological work, often we are asking our patients to be willing to put on the table, put in the room, their sort of vulnerabilities or what they might see as weaknesses. And that can feel very disempowering and very scary and frightening. However, if we can sort of take that perspective and understand it, or consider possibilities, that can actually increase our empathy and even decrease our own discomfort in how to respond. If we can sort of understand some of the roots of where some of their behavior and comments may be coming from. And with that, I'm going to turn it over to Tom to talk about a particular model that was put in place in large part by psychologists within VA about 13 years ago, about understanding how to conceptualize and then manage particular kinds of inappropriate behaviors, especially sexually inappropriate behaviors. So go ahead, Tom.
Yeah, thank you, John. And actually, in preparation for this talk, this is one of the articles that really spoke to me in terms of how to kind of organize my thinking when I'm confronted with inappropriate behaviors in general. Because I know that when comments that kind of come my way in session, or when I'm supervising other folks who are doing therapy, some of these comments and behaviors can be kind of destabilizing in a sense. And when I'm caught off guard, or kind of hits in a sensitive area of some kind, I may have these knee-jerk reactions that I'm just reacting to. And so in some ways, how do I kind of take stock of my reactions in the time there, and how do I kind of get back to more of a clinical footing? And this Hartle and other article really provides an overview of that for me, to really recognize, okay, what's my role here? And reminding myself, what's my willingness to listen to and regard this person in front of me, being able to kind of absorb what they're saying, not necessarily accept what they're saying, but putting it in more of a clinical context. And then continuing to remind me of kind of what my role is in that moment in some way. So could you move to the next slide, please, John? So one of the ways that I use, and this is just kind of how when I react to, like, how do I reorganize my experience a little bit? It's a little bit artificial to begin with, but then it starts feeling natural as we go through it. So looking at this across a couple of dimensions, looking at considering the possibility, is this something that's unintentional kind of response, behavior, comment, or is it something that's intentional? This person actually doing this and knowing that they're making comments that may be inappropriate. And then in some ways, some kind of implication about maybe some of the motivation for some of those comments. So could they be affiliative, meaning to get closer to the clinician or provider, or is it meant to distance or to just provide some kind of to get the person away? So I have some examples from the article in the next slide here. Yeah, thank you. So some examples, and this comes from sexually inappropriate behavior, but we can add other kinds of behaviors too. So when we look at this, I'll pay attention to the first column here. Unintentional comments or behavior. So not aware that the behavior is inappropriate, but there may be some kind of different purposes or functions for this. So an affiliative one may be, desires to bring the clinician closer. So maybe commenting on the therapist's attractiveness, or maybe trying to kind of root out, maybe considering the role of the day, kind of, political stances in some ways, or, other kinds of opinions about this, just trying to kind of get closer to the clinician in some way. And then on the other side of that, the distancing aspect of this, intended to disrupt the relationship between the client and the clinician. So this is the pushing away part of this. So this can come out of, we all have our kind of initial reactions when we're caught off guard. I know some of what I do when I'm caught off guard, but what about other people? That this vulnerability of being in particular therapy. And I come from trauma world, where I'm working on PTSD related traumas, and part of my work is to do trauma processing. So a big aspect of the presentation of folks with histories of trauma is an avoidance aspect of, like, let's get away from these uncomfortable topics in some ways. So maybe I just naturally respond with anger or kind of disruptive comments as a way to push people away. And in some ways that makes kind of that a functional sense in a way for kind of maintaining how maybe PTSD presents itself. So in some ways you can kind of see that that's unintentional. And then when you switch to the other side of this, the second column there about intentional, so people are actually aware of the inappropriateness of this behavior, but they're still doing it in some ways. And I'll get to that idea about motivation and make implications about motivation as well as we go through here. But the intentional, people are aware of the inappropriateness, and if it's designed to be affiliative, so bringing closer to the clinician, maybe the client knows the limits of the professional relationship and is still making these statements. This could be, asking the clinician out, or let's go to dinner or lunch, or just trying to kind of combine in some ways or get closer. And then the distancing part of this is just this could be flat out leering at clients, leering at the clinicians, making intentional comments to kind of push away in some ways. So this was the hard one, and I think this is the one when I think of that this talk, I think of this one as the hardest quadrant to respond to. That there's intentional about this, and it's not necessarily about how can we work with this, but it's just like how do we. I don't know. My response is like, how do you contain it in some ways, but respond appropriately in your role as a professional. So let's switch to the next slide. So in looking at this, so this is the stance. So like once you kind of set aside, okay, let's put it in a quadrant to start kind of thinking about it, get past my first reaction. We can look at some of the kind of the ways to respond to this. So start asking ourselves this question of like, okay, what could be the source of unintentional, inappropriate behaviors? Does this, could this mean that maybe our clients, maybe there's just knowledge deficits of really not really knowing how a professional relationship works in therapy or other kinds of even medical contexts. Maybe there's not a lot of socialization into, what professional boundaries are. It's like what is appropriate and what is not appropriate for therapy in general. And related to another source is that maybe they're just anxious, they're sensitive, and that's just kind of one of the reactions to this. So that's important to consider. And then as John was talking earlier, is that, just asking pointed questions about very personal things can be pretty intrusive. So there's that sort of kind of reaction there. And that kind of has a different kind of flavor to it as opposed to what would be intentional. And then we, add stress and anxiety about, not only am I talking about sensitive issues, but then if there are other components that are layering onto stress and anxiety, that can certainly maybe exacerbate some of these behaviors in some ways, these reactions. And then, just highlighting that point of, especially in therapy, trauma process work, for example, or just deeply personal work, is that there's this high expectation for maybe disclosure to a therapist or a provider in some ways, and that is not necessarily reciprocated, I should say. And this can be interpreted as intimacy in some ways, that sharing important personal stuff can be replicated that way. So just, thinking about this may be an attempt just to get more closely to the clinician in some ways in terms of this quasi-intimate kind of experience, not when we're not really understanding that there's a professional component to that. So when you look at that, it all boils down to, really our clinical response here is to educate. What does it mean to be in a professional relationship? What is appropriate, what is not appropriate? What are our limits of our clinical role in some ways? So that's actually, kind of one of the easier ones, is that when you go, okay, I understand that they just need to be educated about the role of this. So next slide, please. And then with the intentional behaviors, this is the part about, people may be habitually or purposely treating others as objects. And this could be something about that it replicates in a professional environment too, that, this may be happening with coworkers. It may be happening with, of course, in the relationship there, in the professional relationship, it may be happening with, community members. But it's that idea that it could be a possibility that this is maybe something that's bringing someone into kind of this this therapy relationship that is being replicated in some ways. This could be an attempt to, maybe dominate or degrade the professional in some ways. Well, could be. Once again, we've got to be careful about assuming motivation here. And then flat out the power differential that can happen in any kind of professional relationship. This person may make recommendations or decisions about my care. I don't like to be in that position. This comes up a lot with trauma work in some way, in many ways with veterans who I work with. Is power and control is a big part of this. And in any kind of disruption in that dynamic of that may kind of trigger some of these things. And once again, that's more kind of clinical fodder, as it were. It's clinically important to pay attention to in some ways. So these intentional behaviors can, either be affiliative or distancing in some ways. So go ahead, next slide for me. Thank you. So this is the warning part of this, is that, we have to really attend to the idea that, sometimes we make assumptions about kind of motivations for folks, about why they're doing what they're doing in some ways. And I'll tell you what, I don't know about folks out there in the audience, but sometimes I'm pretty bad at mind reading. I'm pretty bad at it. So I may make kind of assumptions that, like, this person is intentionally doing this in some ways. And I do have to check myself as a part of this, like, well, how do I know that in some ways? Cognitive work works on me too. So it's important to kind of pay attention to that. It's like, am I just making some assumptions here without checking them out? Distancing maybe, certainly an attempt to gain some kind of breathing room in a way, that maybe thinking through some very difficult things, and this is a way to kind of push that out in some ways. This may be an expression of discomfort with the provider. Maybe, sometimes we just don't work well with some of the folks who we're working with in some ways, especially in this one up, one down kind of position that can happen in these therapy situations. And then, another possible motivation could be just flat out just looking to make the provider feel uncomfortable in some ways. That is the goal in some ways, which can be difficult, because in some ways, whatever you do to kind of respond to that, in some ways it may be kind of intentionally blocked or kind of worked around or something. It's like, I'm doing the best I can, but it just seems I'm being blocked at every level here. At this point, with their intentional behaviors, they may be pretty resistant to change, even with feedback related to this. So that leads us to, what do we do about this? As John was talking before, reaffirming professional boundaries, just reminding, this is my role. Here's what I need to provide for you. I'm here to, provide my best services, basically. So I'm not, trying to maybe decrease, I'm not giving them the good stuff. I want to be, we want to be kind of equal and, be able to provide our interventions at an equal manner across everybody. So anyway, go ahead, next slide there. So a few things to consider as a part of this is that, all of our interactions are data. And this is the thing that helps me a lot. This is what I tell myself is, this is all data. And then really in some ways asking ourselves, does this show up in other places? Does it show up in work? Does it show at home, et cetera? And just considering that, is this more of a clinical issue at this point that you can actually work on? Let's see, and then asking the question, is this developmental? Is this something that where folks this is how I've always learned how to interact with other folks, other people, my family, my peers, media, et cetera. This is just kind of my skill set at this point. And if it reflects learning difficult or shortcomings or different learning environments, basically, that's workable in some ways. So we can actually work with that. So once again, my warning down the bottom left there is just proceed tentatively when considering motivation. because and maybe check these out in some ways, because we may be going down a certain path and not necessarily appropriately so in some ways. So initially think about a plan of response. You don't have to use this model in particular. Use your theoretical orientation, but stick to something that provides you this foundation, this bedrock, to kind of help you organize and think about how to make sense of this experience and then move from that, but always checking this out in some ways. So anyway, thank you. All right, next slide. All right. And I think I'm doing this one, John.
I think this is where I go over again.
All right.
So now we're going to get to the practical. What do we actually do? So up until now, we've really tried to provide a foundation for understanding when these kinds of behaviors happen, and sort of our own reaction, and learning from our own reaction and the ways that we might initially respond, and understanding our patients and what may be motivating their behavior, as well as then providing a foundation, an ethical foundation that will help guide sort of what we might do. So one, it is important to respond to the behavior while setting limits on behavior. So remembering that it's not sort of the person's motivations or their feelings or even their beliefs that are being questioned, but it is indicating that there's limits in our professional setting of the kinds of behavior that we are asking them to engage in. So some examples, these are actually examples from the JAMA article that I noted, and she actually suggests having like some pat kinds of answers that you might give that aren't necessarily about a particular behavior, but it can be, we don't tolerate that kind of speech here. Let's keep it professional. Or if there's real discomfort or there's a feeling of being threatened or harmed, to even be able to say, I'm going to leave right now because I don't feel comfortable. So I think that last statement can be particularly important to provide that option for trainees if they are feeling, they're in an encounter alone with someone and they're feeling that discomfort and uncertain how to respond, that it's okay to say, we don't tolerate that kind of speech here, and at this point, I'm going to leave because I don't feel comfortable. And it may be to go get a supervisor, to get somebody else to come into the encounter. To shift the focus from the behavior after setting limits to what the goals of care are and what the clinical encounter is about. So, an example would be, I care about you, but I will not tolerate offensive behavior. So let's focus right now on your healthcare and how I can help you today. And then this last point is to practice. So practice your communication approach. So it can be with a supervisor, it can be with colleagues. If you're working with trainees, plan for and incorporate practice for these kinds of interactions into the training that you do with individuals. And there can still be really difficult situations. So this is where practice can be important. So to anticipate what are the kinds of scenarios that might come up and how might you respond. So practicing how you might respond with with colleagues. In the moment, it's okay to stop and take a deep breath. Remind yourself to remain respectful at all times. Being aware of the things that probably won't work, but you might feel urged to respond to, especially if there's like agitation that's building. And as we know, like telling somebody to calm down, basically you're telling somebody, feel something different than what you're feeling right now. I don't like how you're feeling because it's making me uncomfortable. I want you to change how you feel. That's usually going to escalate the situation rather than sort of fanning the flames rather than helping. Again, focusing on the goals of treatment. We are here to help you or your loved one in the case of working with, say if you're talking to a patient's family member. and we're here to help you get your healthcare needs met. Of course, avoid name calling or derogatory kinds of comments. Well, being assertive in the moment when you encounter inappropriate behaviors. Oops, skip too fast. So here's some ways of looking at how to respond to these inappropriate behaviors. So if you are engaged in these circumstances, there can be an embarrassment, especially if you had that sort of often typical response initially of sort of freezing and not saying anything, or sort of slipping by it, or pretending it didn't happen, or not acknowledging it. And it can be hard to then bring that up to somebody and acknowledge, yeah, this is what happened. I don't think I responded very well. This can be particularly challenging for newer clinicians or for trainees to be able to acknowledge these. So having professional discussions with supervisors and colleagues. If not, these can be really isolating experiences. You know, often this hasn't been incorporated into a lot of training, how to respond to inappropriate behaviors. I think more so it has for those of us who are in mental health professions like psychologists, but not necessarily. And if it's not been talked about, you know, can leave someone to feel, well, I should be able to know how to respond to this, and I have to figure it out myself. But what discussion can do is it can really stimulate that skill development, helping people to develop the skills to respond effectively. Hearing feedback from more experienced professionals or even from peers can be helpful in that development. It actually, in addition to sort of how to effectively respond, just simply hearing about one's own stumbles and trips and times that you didn't respond effectively can sort of ease somebody's feeling of they're not alone and can help validate that. Educating patients can be useful, as Tom was saying, you know, helping them understand what a professional relationship is and what a psychotherapeutic relationship is, and sort of what are the rules of the game of how we expect interactions to go, and what are appropriate boundaries. Being able to and open to discussing this with the patient. Sometimes depending on sort of the nature of the behavior or the statements, it might be that you come back to it with the patient and talk about the interaction and work through it with the patient. Now, in order to expect people to sort of talk about and disclose what has happened in encounters that have been challenging, that really relies on trust and openness, and that can be a challenge. So what are the barriers to being able to do that? So now this is a fairly dated study, but at least from back in the mid-90s, a survey of trainees found that few really believed that their training programs helped them to adequately develop the skills for handling especially sexually inappropriate issues that came up in sessions with patients. And they consequently had a real hesitancy to bring it up in their supervision with their supervisors. And some felt, well, maybe it isn't a worthy clinical issue because it wasn't about sort of their presenting problem. There can be fears of negative responses or judgments, or that somehow they actually might be negatively evaluated and it could impact their career. So consequently, trainees are often reluctant to bring up these difficulties, and they, as I stated earlier, there can be a perception that somehow they have to know sort of how they're supposed to handle these and not have these problems bother them. And there can be the interpretation that, well, they must have done something wrong if they did something that could have elicited behavior, or they didn't respond effectively. And there's that ongoing concern about the supervisor might respond negatively if I talk about this and sort of indicate how to respond. So really, many providers are left with trying to navigate this on their own. So what might you do? Having an environment and a culture where talking about these challenges and sort of how people have either successfully or not so successfully managed through them can be really helpful. It can help sort of set the stage for the expectation that we talk about these sensitive topics and we work through them. We build skills around them. If those discussions are not supported or they're dismissed, it just really decreases the chance that there'll be further discussions or especially trainees will actually be willing to disclose maybe even more serious struggles that come up. And particularly if, like, our response as a supervisor would elicit some level of shame, then it's very unlikely that a supervisee would be willing to disclose things. And if we even give sort of a perception or indication as a supervisor that, you know, I really feel uncomfortable with talking about these issues, that can be a barrier. So again, having that environment and that culture where people feel open to being able to talk about these things and work them through. In some cases, there can be sort of some ambiguity about what is said or what is done, you know, whether it's looks or glances or sort of veiled comments. And so if it's not clearly inappropriate, there can be a reluctance to sort of bring that up and want to talk about it. So there should be openness to doing so. But if you're able to talk about this with either other professionals or with supervisors, it really provides an opportunity to, one, normalize that these kinds of client behaviors happen. They're almost inevitably going to happen at some point. And it also normalizes that we often don't have a perfect response. You know, even when we sort of have our statements and we're all prepared, it might backfire. It might not sort of have the intended reaction from the patient. And yet we have to be able to talk about that. So validating and normalizing that these things happen and that we have these kinds of internal responses like that paralysis in the moment or trying to provide a response and it not being perfect, that happens. And it really falls to supervisors or program managers to really set the environment that allows these discussions to happen. It can really help develop better responses for the future and reduce the negative impact of experiences. So within the VA, there's actually multiple resources that are available to help staff in meeting challenges and difficulties that patients or family members might bring to the clinical encounter. Now, some of these resources are only available internally to VA staff, but some of them are actually available externally as well. So an example from the National Center for Ethics in Healthcare is a podcast called Sound Ethics, and the link is here. And it's this is from a series of podcasts on managing difficult situations. In this case, it's when there's conflicts between providers and patient surrogates, and how might you manage those conflicts. The VA also, as those of you who work in the VA are aware, has a workplace violence prevention program. There is both an internal VA SharePoint site here, but there's also a public-facing external website that people can go to read about the workplace violence prevention program. And they have a lot of resources. And then one of those resources is sort of program requirements. And this is, again, an internal VA SharePoint site, but things that are available to staff in sort of what is required to actually get somebody engaged in the workplace violence prevention program. And then ethics consultation is often a place that one can go to in helping to sort of delineate what's really appropriate ethically for me to do. So anyone within VA, all facilities have an ethics consultation service. There's a link at the bottom of this page for a place that you can go to identify who's your ethics consultation coordinator at your facility. Most facilities who have an ethics consult service or an ethics committee will have a way to contact them. And this is where there is some uncertainty or conflict about values. And the right thing to do is not entirely clear. Or even when you think it is, this is something that's available to help you work that out, to look at the what are the values that are in conflict, and how might you then from that determine sort of what's appropriate. So now we have a few minutes for some discussion or questions. And so we sort of put together some questions that might sort of guide feedback from you, but I'm guessing you may have questions in the Q&A section as well. Gail, were there some questions that came in?
Hi, John. Yes, there sure were. So thanks so much. But there are a few here, so I will try and go through them. We've got about 8 minutes left. So if you both can think about that as you respond. Okay, so the first is from Alexia. Hypothetically, if a patient requests a different provider based on an issue, such as race, gender, etc., is it best to reassign to another provider if available, or to refuse the patient's request?
Very good question. This is a really, really common question that comes up, at least, you know, in my experience within VA, this comes up. And various places have sort of some guidelines or rules around under what circumstances can a patient, you know, request a new provider. In some places it's, well, you can request once, but if you're repeatedly requesting, we're not going to allow that request. So it really is very context dependent. This can be an example where an ethics consultation can be really helpful, because on the one hand, you want to provide care that is respectful to the patient, that can help the patient where they feel that they can actually engage effectively with the provider. On the other hand, you don't want to be sort of perpetuating discriminatory behavior towards providers to be able to do their work as providers and provide patient care, and perpetuating stereotypes or discrimination towards people. And so those values can be in conflict, and sometimes an ethics consult can really sort of help sort that out. In this particular circumstances, how might we resolve that? Any other thoughts you have, Tom?
Yeah, I was, you know, just thinking about the idea of just asking, you know, what are the goals of the treatment there? You know, are we putting on our own values about here's how I think this person should be seeing things, and maybe we should just, for a therapeutic sense, just keep them with the provider in some ways, but maybe that's not necessarily what is bringing them, and it asks that question of like, how much do we impose our own values on our patients at this point? So I like what you're saying about that context dependent part of this is like, for what purpose, for what goal in some ways. We have a similar policy here in Salt Lake that you can request once, but you need to have some good reasoning to request again before a switch provider.
Yeah, the JAMA article that I cited actually opens with a description of a situation. I don't remember whether it was in the emergency room or an inpatient ward, but basically the patient is rejecting the resident for going in for being too young, and then the chief resident because they were Muslim, and then basically they were like finding reasons why they didn't want to see any of the people on the team. And finally the attending staff person, who was a woman, went in and said, you know, I understand that you don't want to work with some of the providers, but here we are your team and we all are going to work with you. And that's what the expectation is. We're going to provide you the absolute best care that we can. So it really does depend on the circumstances.
Thanks. We'll try to squeeze in one more question. You really focused on some great strategies when you're working with folks individually, but Carice wants to know what tips do you have for addressing hate speech or prejudice speech in a group therapy setting?
You want to start with answering that, Tom? I think you probably oversee a lot of groups in your PTSD treatment.
A little bit here and there. In particular, when we're working with groups in a PTSD clinic, lots of intense issues that can pop up and very sensitive issues in a way. And really, it comes down to the seeds that we plant early on in the group therapy of kind of what are the expectations here? What are we working on? What are we not working on as well? And when we start kind of veering into those if there's prejudice speech or hate speech coming up, it is really incumbent on us to really point those out early on about, is this really part of the goal of this group in particular? And then, with that, we're working with as a group, we're working with a lot of people at the same time, and just pointing out that a person, someone's comments affect all the others in the group as well, and we all have responsibility for everybody in this group. And then the thing is small things early on I find can get repeated and grow bigger, and then people are leaving maybe feeling unvalidated or insulted or denigrated in some ways. So once again, similar in the way for kind of this, if you're a supervisor, being able to address this, even though it may be uncomfortable, it's really incumbent on the clinician to make those statements and stumble through it. I've made my career stumbling through things, but being able to say that and putting it out there can do a lot for maybe bringing someone back into kind of recognizing the limits of this, where they've kind of come off a little bit, and being able to acknowledge maybe some of the folks silently who may be kind of being wounded in a way.
Yeah, I think it really helps model appropriate behavior and how to address things that are difficult and challenging. So in a group setting, how you respond is going to be viewed by the others, because if you were offended, there's likely others, patients who are in the group, who are also offended. If it's not addressed, that's going to be recognized in and of itself. So it clearly has to be addressed within the group. So that's an opportunity to model appropriate behavior.
All right, thanks. We're going to have to let that be the last word. John and Tom, there are a few more questions that are in the Q&A. If you don't have, you do have a few minutes to spare, if you wouldn't mind taking a look at those, and you might be able to respond directly in the Q&A box. But for everybody else, I know people probably need to run to their next thing. I was just going to say, you can also contact Drs. Billig and Mullin directly. There are their email addresses. For those of you who are interested in getting CEUs, I am posting the link to the SurveyMonkey questionnaire that you will need to complete in order to receive your CEUs. Everybody who's registered for this webinar should be able to get an email following the webinar in a day or two that will share information about the CEUs. Those of you who are not Division 18 members, again, you can get one CEU for $15. Division 18 members get their CEU for free. So all that information will be contained in the email. So thank you all for coming. Thank you to Dr. Billig, Dr. Mullin, for your fabulous presentation today. It was really helpful. Hope you all have a good rest of the day. Thanks.